Welcome, everyone. Thank you so much for joining us today. For those of you who don't know me, my name is Rachel Schrader. I'm Vice President of Clinical Care and Education at Parent Project Muscular Dystrophy. And we're really excited to bring to you today 3 amazing speakers who are going to share some education and enlightenment with us on pain management and Duchenne. I think this is a topic that we all acknowledge is really important, but perhaps don't have really clear guidance or talk about enough. So we've lined up 3 great speakers who are going to talk about pain management and Duchenne from a variety of different perspectives. So without further ado, I think we'll go ahead and dive right in. We are going to start by hearing from Dr. Susan Epcon, who is at Children's Hospital Colorado from the rehab department. Dr. Epcon, go right ahead.
Excellent. Well, again, thank you so much, Rachel, for the invitation, and thanks to Parent Project Muscular Dystrophy as well. I am happy to be here. As Rachel said, I am a physician. I'm a pediatric rehabilitation physician at Children's Hospital Colorado. I've been taking care of boys and men with Duchenne muscular dystrophy for 20 plus years now, which is quite a long time. And I say boys and men because I also, while I'm in a children's hospital, I run an adult clinic for men with Duchenne. And in fact, tomorrow I have men who are well into their 30s. So I will talk today a little bit about pain across the lifespan. As we talk about Duchenne in many different ways, we talk about ages and stages. And so you'll hear me refer to that as well. I'm going to talk about different causes of pain. I'm going to talk about how we think about evaluating pain complaints, and then discuss a little bit about some treatment options. I'm going to talk about more of the options from a medical standpoint, because I know that Claudia is going to be talking about it from a rehabilitation standpoint. So let's start and kind of level our field here and talk about the definition of pain. And when I think about pain, it is generally considered an unpleasant sensory or emotional experience. It's usually associated with or resembling that associated with actual or potential tissue damage. That's a medical term. And I want everybody to appreciate the fact that pain is different for everyone. We feel pain differently. I use the example of myself. I stub my toe and it's like the world is falling apart versus someone else who might stub their toe and it's like nothing happened at all. And so that's an important concept because pain is very individual. And it's important for a provider like myself to really appreciate that while I might not believe or think that that the injury or accident might have caused this tremendous amount of pain, in fact, for that individual person, it may be significant pain. There's 2 kinds of pain. There's nociceptive, and so that's either somatic or visceral. What I mean by somatic, it's pain from an injury to soft tissue, like bones or skeletal muscle. It's usually something that you can point to. So I can point to my finger. I can point to my back. I can point to my leg and say, that's where my pain is happening. There's visceral pain, and that's pain that's coming from our internal organs. It could be our heart or our lungs, our abdomen, our appendix is a great example of that. Those complaints tend to be a little bit more generalized, a little bit more vague, a little bit harder to pinpoint. And then there's neuropathic pain, and that's pain coming from nerves. When we think about the description of neuropathic pain, it's typically described as a burning pain or a pins and needles pain. If you think about when you hit your funny bone, which isn't so funny, your elbow, that usually causes a pressure to the ulnar nerve, and that causes a shooting pain to your hand. That's a great example of neuropathic pain. Or if you're sitting too long, or you're driving in a car too long and your leg falls asleep, that's neuropathic pain. So when a provider is trying to assess your pain or your child's pain, we think about a few things. We ask about the location. So where is the pain? As I said before, if it's pain coming from a bone, so a fracture as an example, it's pretty easy to localize. When it's coming from visceral pain, so pain coming from the intestines as an example, that might be a little bit harder. For kids, I usually will say with one finger, point to one spot that hurts the most. And that usually gets me at least in the near vicinity of where the pain is. I want to know about the intensity of the pain. How much does it hurt? In the upper right corner, there's some faces that can be used for children that can represent different intensities of pain, with 0 as no pain at all, and 10 is the worst pain ever. For an adult or an older child, you might just use a visual scale of 1 to 10 and ask for that similar intensity score. I want to know whether it's acute or chronic, so the duration of the pain. As a physician, I'm going to think very differently about pain if it's acute, meaning it just happened, more likely from an injury versus something chronic that's been going on for a very long period of time. My thought process changes, my evaluation, diagnostic intervention, diagnostic tools, and even interventions may change based on the duration. What's the characteristic? Is it sharp? Is it dull? Is it throbbing? What makes it better or worse? Have you tried Tylenol or Motrin? Have you tried ice or heat? What makes it worse? Sitting in a certain position, being in my wheelchair, standing up, sitting down. And then most importantly, as a rehab provider, I think about quality of life. I think about the things that kids and adults want to do. So how is that pain interfering with that? Is it so painful that you don't want to go outside and play? Or you don't want to go to school if you enjoy school? So as we think about causes of pain, we're going to talk about pain in the arms. We're going to talk about back pain, abdominal pain, a little bit about headaches and chest pain. And so I'll start with pain in the extremities. What I mean by that is pain in the arms or legs. The first thing I'll say is that calf pain is really common in boys and men with Duchenne. I see it in our kids who are ambulatory. I see it in our men who are non-ambulatory. Oftentimes the pain is non-specific. It just, kids will say it hurts. Some might say it's cramping. If a parent or someone else puts their hands on the calf, they may not feel anything. Some parents have told me that the calf feels especially hard compared to its baseline. Again, it's very common. In terms of evaluation, I want to rule out other things. So if this is a chronic issue versus an acute issue, there's been no trauma, then I might try something like massage, a warm bath, even some Tylenol, as that seems to really help that kind of pain. If it's an acute onset of pain in the arms or the legs, the first thing I think about is a fracture. And one thing to keep in mind is it doesn't have to be associated with big trauma. It doesn't have to be associated with a fall. It could be minimal trauma. It could be a kid bouncing on a bed, someone going through a doorway and just catches their leg a little bit. And that's sometimes enough to cause a fracture. One thing to remember is that boys and men with Duchenne have reduced bone mineral density. That's what gives you those nice, strong bones. It's related, for those who are not walking, to immobility, not being able to walk. And for boys who are walking, they're not walking and running at the same pace as other boys. And that's what really helps to increase bone density. And so you are at risk for fractures, again, related to trauma or even minimal trauma. When I think about back pain, again, if it's an acute or even a subacute complaint of back pain, especially in the mid to low back, I think about compression fractures. I just talked about the boys with Duchenne are at risk for fractures. I mentioned the immobility and weakness. Also, the steroids that they're on may contribute to that. So I've had a number of kids who have been in their wheelchairs and gone over a bump, been in a car and hit a bump, and that caused acute back pain. Oftentimes there's point tenderness to the location, and an x-ray, a side view, is going to be helpful in determining whether or not there's a compression fracture. From a treatment standpoint, sometimes it's symptomatic, meaning Tylenol or Motrin, or a hot pack or a cold pack. Other times we'll use medications that are either stronger or medications to reduce the future risk of compression fractures, like a bisphosphonate that you might be familiar with. Visceral pain, again, that's that pain coming from the organs. It might be nonspecific, a little bit hard to describe. Back pain, though, when it comes from the kidneys, can be quite painful if you have a kidney stone or an infection. Constipation can lead to some complaints of back pain or side pain. The diagnosis for that may be an x-ray, it may be an ultrasound, and the treatment, depending on what we find, is going to be related to that. And then musculoskeletal pain. And I use that term really broadly. And I know, Claudia, you're going to be talking about musculoskeletal pain, so I won't spend too much time on it. But what I will say is it's common. We see it in our ambulatory boys. If you think about that lordotic posture, so that posture with the tummy out in front and a sway back can lead to some kids having some musculoskeletal or muscle pain. It can be related to positioning in a wheelchair. I've just moved forward. I've just moved back. I can adjust myself in many different ways because I have good trunk strength. If you're someone who has a lot of weakness, you may be sitting in the same position for a long period of time, and that can lead to some pain. Abdominal pain, constipation are probably the most common reasons why kids with Duchenne and other kids will have abdominal pain. The history will be decreased bowel movements, hard stools, and evaluation might be an X-ray that shows us the burden or how much stool there is. And then the treatment will be use of medications to move that stool through. It could be enemas, it could be oral medications. There's lots of different options that you can discuss with your primary care providers. Abdominal pain related to steroid use, while we don't see it frequently, is something I think about. It's a gastritis or an inflammation of the lining of the stomach. Reflux or heartburn can cause abdominal or even chest pain. And then in our older men with Duchenne, we see something called gastroparesis, or the delayed emptying of the stomach. So you eat fine, but the food just is very slow to move through into the intestine, and that can cause some abdominal pain as well. Chest pain, while we always think about the heart, because that's the thing we want to make sure that we understand and treat if that is the cause of chest pain. The reality is, especially for younger boys, chest pain is frequently not cardiac in nature. The evaluation for cardiac or chest pain is going to be likely an EKG. But if the quality of the pain, meaning, or the location, meaning I can just push right here and that's where my pain is, or right here, oftentimes we think about that as more musculoskeletal pain. We could see rib fractures, we could see reflux, we could even see pneumonia as examples of non-cardiac causes of chest pain. Evaluations, again, maybe x-rays, it may be EKGs, and the treatment is going to be dependent on the cause of that chest pain. And then neuropathic pain, I already mentioned it. Sitting too long in one position will cause numbness or tingling in your leg or your foot. If you're leaning on an armrest too long, I mentioned that ulnar nerve, you'll get numbness or tingling, and it's generally in that fourth and fifth finger. Repositioning is going to be the treatment for that. So other causes of pain. I want you all to remember that kids are kids, adults are adults, and you can have non-Duchenne related causes of pain. So ear infections, throat infections, appendicitis are other examples that we see commonly in kids of all ages that need to be treated appropriately. I'm going to spend 1 minute on this slide. This is unpublished data from a survey that we did in 2021. Thanks to PPMD, we were able to send out almost 3,000 emails to potential survey respondents. These were men over 18 who have Duchenne or families who have boys under 18. We wanted to understand the use of cannabis in Duchenne, and there was some specific questions around why you use it. And the reason I'm including this slide is that there was a question about pain, and if you are using cannabis for pain, what benefit are you seeing? And what you can see here is, and I'll just to orient you, when we talk about cannabis, it's actually the products are the cannabis sativa plant, and there are a couple of different products. The THC is what gives you the high when you are using cannabis products, and CBD, or the cannabinoid CBD, is again one of the byproducts of the cannabis sativa plant, and there may be some different characteristics of that might people might choose to use CBD for things like pain. I'm not endorsing this, but what I'm sharing is that of the respondents, of which there were 252, when I asked them whether it cannabis helped their pain. About 43% said that the THC seemed to help a lot, and 32% said the CBD component of the product that they were using helped a lot. Moderate benefit, 33%, compared to the 47%. You can sort of see that slide. So again, this is data that we have that I hope to publish in this next year that will give men and families an idea of the use pattern for people with Duchenne. So I am going to summarize and then hand the podium over to Claudia. As we think about pain in boys and men with Duchenne, it is common and there are many causes of it. When you go to a care provider with complaints of pain, they're going to take a comprehensive history, again, understanding whether it's acute or chronic, the location, the intensity, what you've tried. Those are all questions that are going to help inform the provider in understanding what imaging studies or x-rays they might want to do, or other diagnostic tests, what labs they might want to order. And then the treatment plan is going to be related to the underlying cause of the pain. There are medication treatments and there are also non-medication treatments. And I guess that's a great segue into introducing Claudia, who's going to talk a little bit about the rehabilitation focus for pain in people with Duchenne.
So thank you for having me today. I'm going to continue the conversation about pain management. And this really goes for boys and men with Duchenne and with Becker muscular dystrophy. So as Susan said, there could be many reasons for pain. I will be focusing primarily on musculoskeletal pain. And these could be related to falls, for sprains and strains, and also post-fracture, edema, muscle weakness. That what comes with muscle weakness would be an imbalance, overuse of a particular part of your body, immobility from not being able to move as you used to, nerve compression. As Susan mentioned, maybe it's your arms positioned on the armrest. It could be compression of the sciatic nerve, which is positioned where your gluteals are, your rear end. Contractures that you might have either at your ankle, behind your knee, maybe the front part of your hip, and then deformities that might result from those contractures. And again, you know, pain can manifest in many different ways. And I've just put some of these words here because it really depends on the person, the way they describe pain. And it depends on what kind of pain they're having and where that pain is located. So someone might describe pain as an achiness. It could be a sharp pain, might be a tingliness that they have, a stiffness, tenderness, numbness. There are lots of words that describe pain. Pain can be anywhere in your body. And as I said, I'm going to focus mainly on musculoskeletal pain, which has to do with joints and or muscles. In Duchenne and Becker, there are some key areas that keep coming up as areas that boys and men often complain about. The back is one of those, and primarily the low back because of the posturing over time with the increased swaying of the back or lordosis. The neck is often an area that comes up. The shoulder girdle, or just the shoulders, the shoulder blades. The hips are another area that are frequently painful over time. Susan also mentioned the calf muscles. If you're still up walking, often feet will be an area that may end up being painful, particularly as a person is approaching the transition of being ambulatory to non-ambulatory. the soles of the feet, the small muscles in the feet often will start cramping. And then the hands and the fingers. When we're addressing pain, we want to invest the cause of the pain. It's really important to try and figure out why this person is having pain, and that can help us actually treat what the pain is. So we have to be really good problem solvers to actually figure out what our options are for changing this input. And that often requires consulting. And so we want to work as a team. So often we need to get a physician involved to rule out some of these other things that Susan talked about in her talk, to make sure that there aren't any other issues that we might be missing as therapists. Actually addressing pain from a rehabilitation standpoint, there are many things that we can do to actually address pain from this aspect. So some of those would be stretching, positioning, the use of TENS and acupuncture, which we'll talk about briefly in just a minute, massage, deep pressure, splinting when necessary, bracing if necessary, adaptations and modifications when necessary, the use of heat and or cold, compression and or traction of a joint, and gentle mobilization with oscillations and pendulum movements can often help relieve pain. So let's look at TENS and acupuncture. Both of these are probably considered alternative approaches for the management of pain, and they've both been around for a while. The acronym TENS stands for Transcutaneous Electrical Nerve Stimulation. This uses a low voltage electrical current from a small portable device that runs on batteries. These impulses are delivered at or near nerves for interrupting, blocking, or changing your perception of pain. So this is a portable unit that you can attach to your waistband. And little electrodes are placed, as it says, near or over where nerves are innervating muscles. Acupuncture has been around for a very long time. It's actually a form of traditional Chinese medicine that has commonly been used to treat pain. It involves inserting very thin needles into the skin along meridians over your body. And these are key areas along your body. In addition to treating pain, this has often been used just for overall wellness and the management of stress. Stretching and massage. I'm sure everyone is familiar with stretching and massage. And we know just in the general population, aside from neuromuscular disease, that stretching and massage feel good and generally make you feel better. And it's the same in this population as well. We also know the research tells us, and it has been well proven, that stretching and massage improves circulation. It helps to move the joint through its available range. It can relieve muscle spasms. It can reduce cramping in the muscle. It reduces soreness and achiness in muscles and around joints. And deep pressure, when needed, I think in this population, there is some caution with deep pressure. And so we have to be very specific when we use it in Duchenne and in Becker muscular dystrophy for things like sciatic nerve pain, where deep pressure might be warranted. Deep pressure and deep massage can actually be harmful in this particular situation because it puts a lot of stress on the cell membrane. and can actually cause some micro tears in the cell membrane. So there are some specific reasons to use it, but I would just put a big caution next to the use of deep pressure. Heat, cold, compression, and traction. So heat relaxes muscle, but I would also say be careful with the use of heat. Too much heat can actually weaken a muscle. And the example that I put here is the use of a hot tub. A hot tub is delicious. I mean, it really helps you relax. But if the water is at a high temperature, it can just make you melt like putty. And that just goes for the general population. So if you have a neuromuscular disease and you're in a hot tub that's at a higher temperature, you're going to have trouble getting out of the hot tub and you're just going to be wiped out. The other thing to be cautioned about hot tub is even if it's at an appropriate temperature, around 98 degrees, if you stay in there too long, you'll also feel very weak when you get out of the hot tub. So just some cautions on the use of heat. Cold can actually decrease inflammation. So if you've turned your ankle, you've just made a wrong step, if you've fallen and you have fallen down onto your knees, if you've hurt your back, ice can be very helpful because it can increase circulation, it can decrease inflammation, and it can be a really good thing to use ice after an injury. You want to apply it for about 20 minutes. The caution here is that ice and cold can cause burns on your skin if it's really cold. So you use a thin towel on top of your skin before you use an ice pack. Compression is good if you have some swelling, and ACE wraps work really well for this. What you don't want to do with an ACE wrap is you don't want to make circumferential turns around the area that's swollen. Instead, you want to use diagonal wrapping or a figure 8, depending on which area of the body you're wrapping. And then traction can really help relieve pain and discomfort around large joints, and particularly the hip. This is a really good joint to actually do some gentle traction, and that can actually relieve a lot of pain. Splinting and or bracing can be very helpful if you have painful joints that need to be stabilized. So splinting can stabilize a body part and help to decrease pain. And I've just put a picture of a wrist and hand splint here. And bracing can help maintain a stretch for prolonged periods of time, and it can also help stabilize a joint. So both of these are good in terms of potentially reducing pain. And then, of course, adaptations and or modifications. As your body changes, as you grow, as your body progresses in terms of maybe as weakness progresses, you'll need to make changes in your environment. You'll need to make changes in your bed. You'll need to make changes in your bathroom. Changes will be occurring in your ability to perform activities of daily living. So you'll need to make some changes in some of those activities. You'll need to assess the different environments that you work in, that you play in, whether it's school, whether it's your home or your work environment. You'll need to look at your routines and maybe change those, adapt those, modify those. Surfaces that you work on and play on may need to be adapted. And then, of course, wheelchairs. Positioning in wheelchairs, if you're using a wheelchair, is critical. as your body changes, your wheelchair needs to change with you. So reaching out to a therapist that deals with these kinds of things and is adept at making adaptations and modifications is really important. And finding a vendor, an equipment vendor that can work in harmony with a therapist is the best approach. So a team approach is really important. So be creative while you're problem solving pain issues. Ask a lot of questions. So the provider needs to ask questions, and you as the consumer, you need to ask a lot of questions. Collaboration is really the key to success here. Working as a team is really the key to success, and be a problem solver to solve these issues. I'm going to turn it over to Rachel now.
It's lovely to be part of this. My name is Rachel Thean-Prioun, and I am a palliative care doctor at Cincinnati Children's Hospital, where I care for a number of patients with Duchenne and other muscular dystrophies. I've divided the talk into just sort of three big buckets. The first, I'm going to tell you what palliative care is. And so you guys might be thinking, now, wait a minute, I came to hear a talk about pain. What's she doing slipping this in? I'm going to convince you that pain is part of my responsibility as a palliative care doctor, and not just pain, but also responsibility for other symptoms as well. And then I'll talk a little bit about how we assess and treat pain in patients with muscular dystrophies, building a little bit on what Dr. Epcon said, and moving forward a little bit with that. And then towards the end, I'll just talk a little bit about pain and comfort concerns throughout the lifespan of patients with Duchenne. So to begin, what is palliative care? This is a lot of words. This is the WHO definition of pediatric palliative care. And the words that are bolded or highlighted are done so for a reason. Those are words that patients have said need to stand out when we explain who we are to other patients. So pediatric palliative care is specialized medical care. What that means is that I've done a fellowship in pediatric hospice and palliative medicine. It's for people who live with serious illness, and that's intentionally vague. Serious is defined by the sufferer, right? And saying from the outset, this patient is or isn't, based on diagnosis, eligible for palliative care isn't right. So we are eligible for anybody who has serious illness. We focus on providing relief from symptoms and stress of illness. So we understand that when somebody has an illness, especially a chronic lifelong disease, that it causes not just physical symptoms, but emotional symptoms, psychological stress on the whole family. And our goal is to improve the patient's quality of life, but also the family's quality of life. So we come in and appreciate that one person is part of a much bigger whole group of people, a whole community, and it's our job to see them in that context. We work in a team. So often when I'm in the hospital, I'm traveling with a social worker at least. When I go to the home, often I have a child life therapist or a music therapist or a chaplain with me. We have a multidisciplinary team, and we work together with the rest of the teams that care for a patient as an extra layer of support. So often we are the people who are herding the cats to try to get everybody on the same page to help take care of a patient who has lots of different teams involved. And we can come alongside at any age or any stage of illness. So we really do the best job when we get started early, when we're there from the beginning, and we can get to know our patients really, really well and follow them through years and sometimes decades of their lives, providing continuity of care along the way. We are family-centered. We help with communication and coordination of care. So like I mentioned earlier, we are often the people who are trying to get everybody at the same table to try to get the best care plan developed for our patients. And we're trying to help families choose options that are in line with their unique values, traditions, and culture. So what we mean by that is sometimes medical care, especially in the US, can feel a little bit like a treadmill. This is the next thing. This is the next thing. This is right for you. This is what we're going to offer. But every single intervention along the course of an illness isn't necessarily right for every single patient. And so we come alongside, try to understand what makes your family unique and special? What are you hoping for? What are you worried about? And then how do we synthesize all of that into the right next steps for you and for everybody in your family? to improve all of your well-being. So that's a lot of words. How do I actually introduce my team? I don't read that every time I come in to meet a new patient and their family. So I say, first, we're pain and symptom management specialists. We are one of the 3 pain teams at Cincinnati Children's Hospital. We grew out of pain here, so we have a strong representation and focus on pain management. And that's one of the most common reasons that we're consulted at Cincinnati Children's, to meet patients. The other most common reason that we're consulted is to help families navigate medical decision making. So sometimes we meet families during pregnancy and they are trying to manage uncertainty and make a plan for what's going to happen after birth. And so we try to help them make that plan. And then if the baby's born and they do pretty well, over the course of their life, the family is going to have a lot of more difficult decisions to make. So we hope to, again, just try to come alongside and say, what are you guys hoping for right now? What are you worried about? What's important to you? How are you making meaning of all of this? And then help plan that next step. And then, of course, we're also specialists in end-of-life care. We don't shy away from that. It's part of what we do. It's a really meaningful part of our work, and I think a true privilege. But for the most part, when we come in to meet new patients, that's not why. We're here for all of the other stuff, to walk along with them for years. So for Duchenne, when should palliative care get involved? Is it during infancy? Is it in early childhood when maybe changes are happening and families are getting diagnosis and new information? Is it at loss of ambulation? Is it in adulthood? Honestly, palliative care could get involved at any time point along the course for anybody with Duchenne. So the answer is, honestly, it depends. Crossroads that you may come to consider asking for palliative care involvement are certainly if you have pain or poorly controlled symptoms, including mental health issues, including anxiety or depression. You can ask for a palliative care consult and see what they can offer to help get those symptoms under control. If you're facing an important medical decision, so many patients who we care for with Duchenne at some point or another may be considering whether or not they want to get a G-tube, or whether or not a tracheostomy is something that they want. Those are big decisions that can have lifelong implications. And so it's not our job to say, I think you should do this, or I don't think you should do this. It's our job to say, how are you making sense of all of this? What are you hearing from your team? And then we try to help make the plan that's right for you. If you're feeling unheard by your care team and need somebody to advocate for you and kind of be in your corner, that's something that we do. We also help with coordination of care. To be honest, I don't know anybody in this country who doesn't struggle with coordination of care, so that's a big ask, but doing that is a domain of quality for good palliative care. So that's certainly something that we do. If you're wondering about advanced directives or setting limitations in medical care, we can help with that. Or if you're just looking for more support at home, sometimes our patients are, into their 20s and 30s and not able to do what they wanted to do and saying, you know what, I think I want to stay home. I don't think I want to go back to the hospital. That's a great time to call us and see what we can do to help. So all of that said, how do we specifically put on the pain assessment hat for patients with muscular dystrophies? So a lot of it is exactly what Dr. Epcon said, right? When we assess pain, we follow this sort of algorithm in our minds. In addition to asking, where is your pain? What is the location? We're also thinking through this PQRST sort of mnemonic. And I think we're both telling you this because we want you to be prepared to advocate for yourself when you go in to see your clinicians or your physicians, especially if you have pain. So thinking about, okay, I do hurt. What makes it better? What makes it worse? What does it feel like? And that, again, is getting to the nociceptive versus neuropathic qualities that we've talked about to help us figure out what do we think is the cause of this pain and what kind of medicines or interventions would help treat it, because it's different depending on what the cause is. Does the pain radiate anywhere? That also gives us clues about what's causing it and what might help it. When we think about severity, you saw that FACES scale earlier that goes from 1 to 10. And I do want to point out too, there's not just an intensity in terms of severity. So often when we ask, what number is your pain? I think that we're asking about the intensity, like how strong is your pain? But there's another component to it that is pain unpleasantness. So I can have a migraine that is maybe a 3 out of 10 in intensity, but an 8 out of 10 in unpleasantness. So there can be more than one component to pain severity. And I think it's up to us to try to help tease that out as we're asking these questions too, because sometimes when you're the sufferer, it's all just sort of wrapped up in your mind together. And then timing, like she has said, how long has it been going on? Is this chronic? Is this acute? Is it all day? Is it certain times of the day? Getting that sort of temporal pattern established helps us figure out the best way to treat the pain as well. And then again, how does this impact your life? What is this keeping you from doing that you want to be doing? What is the impact on your mood and your family, because pain is a whole human being experience. It's not just a physical experience. It's a spiritual experience and an emotional experience as much as it's physical. And if we don't try to help with that, then we're going to be missing helping you as much as we can. And if we do a physical exam, of course, we need to lay hands on you and see, where does it hurt? Can we reproduce the pain? What does it feel like when I touch you here or touch you there? Am I causing it to radiate anywhere? Is there tenderness? Are there hot spots or sort of trigger points that are really always annoying for you? We might range your motions and see, does moving your leg this way hurt, or does doing it this way make it feel better, to try to get a sense of what's going on. And then, before I get to medications, and I'm only going to barely touch on medications because I think that's a really important conversation to have with the person who's in front of you when you're in the doctor's office. We cannot adequately treat pain if we're not also asking about anxiety and depression, because having chronic pain is hard. And I think that in and of itself can exacerbate baseline anxiety and depression. But also, if I just give you a pain medication and I don't help with everything else that's going on, I'm not going to adequately manage your whole experience of suffering from pain. And so we always ask about anxiety and depression in all of our patients, but especially in our patients with muscular dystrophies, because we know these are very, very, very common, and we need to decrease the stigma about talking about them and about aggressively treating them so our patients can have the best lives possible. And then finally, we'll come up with a treatment plan. So in addition to thinking about physical therapy and stretching and massage and all of these other things that we've talked about, which are critical importance, adjunctive, sometimes integrative therapies to help with pain, in addition to medications, when we're thinking about medications, we're also thinking about them in the whole patient view. So if we have a patient with really progressed Duchenne muscular dystrophy, we want to limit medications in the chronic long term that can cause muscle relaxation, increase constipation, or cause respiratory suppression. So we're thinking about, if I put an opioid in this patient, is that going to make something worse? If it's just in the short term, it's probably worth it. If we're dealing with somebody who has a ton of pain from a fracture, then we're not going to withhold strong medications in that circumstance. But if we're dealing with somebody who has long-term pain, we may want to really think about, what is the risk benefit of using specific medications at this point in time for those patients, so that we don't make other things worse as we're trying to help with their pain. For neuropathic pain, we use medications like gabapentin, pregabalin, or duloxetine. And the nice thing about duloxetine is that it also helps with mood. It was actually designed as an antidepressant. So we use that a lot in our patients with Duchenne. And then musculoskeletal pain, sometimes we can use non-steroidal medications like Motrin or Aleve. Sometimes we can't for other reasons. Celecoxib is a medication that doesn't cause bleeding, and it usually is a little easier on the GI tract. So we use a lot of that in our patients with muscular dystrophies. And then finally, for patients who have moderate or severe pain, especially patients whose time we think is getting short, we certainly will use opioids, but we try to spare them as much as possible. We have opioids now that are less likely to cause constipation, that are less likely to cause respiratory depression, that actually can help mood. And so being creative about what our toolbox looks like and looking for new medications as they come online is really important for us as well, not to just get stuck with an old toolbox that isn't right for our patients. And then finally, thinking about comfort concerns throughout the lifespan. I love this chart because I think it shows really nicely how pain evolves over the course of life in Duchenne muscular dystrophy. So this is looking at patients with Duchenne between the ambulatory, so those red bars are patients who are still ambulatory, into the late non-ambulatory phase. So those bars are the yellow bars. And you can see frequency is increasing as we're going from left to right. So patients who have no pain at all, that's 8% of patients who are ambulatory, 6% of patients who are early non-ambulatory, and only 4% of patients who are late non-ambulatory had no pain ever. And then those numbers start going up as we move throughout the lifespan. So by the time patients are late non-ambulatory, a quarter of them have pain several times a week, and the rest, almost half of the cohort have pain daily or more than half the day or always. So pain is very, very common in patients with Duchenne in all stages of the lifespan is what I take from this. And it's something that we need to be asking about in every clinic visit so that we can make the plan that's best for our patients. In addition, quality of life, sleep quality, anxiety, and depression are also common. This study was just patients who use non-invasive ventilation. So this is patients who are likely in that late non-ambulatory phase. It was a study out of Italy looking at patients over the age of 18. And I liked this one because they looked at quality of life using a neuromuscular specific scale, and they found high scores, which was lower quality of life for these patients in physical health, specifically in the domain of weakness, which is not surprising, but also activities and independence domains. And then they found that over half of these patients had abnormal sleep quality scores, 20% had abnormal anxiety scores, and 10% also had abnormal depression scores. And these numbers are a little low, even depending compared to my personal sort of experience in clinic, just thinking about the patients who I take care of. We find anxiety and depression very commonly in our patients, and we treat them very aggressively. We reviewed patients here at Cincinnati Children's. This is not published, but we're writing up the paper now. We looked at patients who died with progressive Duchenne, who we cared for at Cincinnati Children's over many years. And what we found was in the last 2 years of life, all of the patients complained of pain and subjective shortness of breath. And most of the patients, the vast majority, also had lack of appetite, constipation, sleep difficulty, wounds, anxiety, and nausea or vomiting. So lots and lots of symptoms as patients progress to the end of life. We were treating these symptoms really aggressively, but what it says to me is that clinicians who care for patients with Duchenne need to be asking and doing a full symptom assessment survey at every visit from 18 on so that we don't miss anything and so that we can be aggressively trying to stay ahead of all of this throughout the lifespan. And then finally, when I think about what does high quality care look like for these patients, there are 2 patient-reported outcome measures that have been created for use by patients who receive palliative care. And I think these are good questions for any team, not just the palliative care team. But the first is, did you feel heard and understood by the palliative care team? If you go see your team and you don't feel heard and understood, then we need to be doing something better, because if nothing else, we can't create the best plan for you if we don't hear and understand what you need. And so if the answer to this is no, we need to be doing a better job. If the answer to this is no, for your other teams, ask for palliative care and we can try to help bridge this gap. And then of course, the second is, did you get the help that you wanted for your pain? Because if we are being evaluated on just whether we assessed pain in all of our patients, that doesn't answer the question of whether we actually helped you. So ask yourself these questions when you go to your clinic visits. And if the answer to these are no, let your teams know so that they can do a better job taking care of you. That's all I have. Thank you guys so much. We'll take your questions.
Wonderful. Thank you so much, Dr. Thien Prayun, Dr. Epcon, Dr. Senesak. That was just really fantastic. And I know that I always learn so much listening to the 3 of you. I think at this point, we'll go ahead and take our last 10 minutes or so to dive into our questions. We've got some really good questions here in the chat. I am going to start with a question that was submitted in advance for the panel, and it's in regard to headaches. So this is from a dad who says that his boys oftentimes get morning headaches, and he learned that it might be sleep related. So they went through the process of sleep studies, BiPAP, all of the things, but they're still dealing with these headaches, and their doctor has suggested that perhaps the tension headache. So with something like that, what might you recommend as far as workup and potential treatment options? Maybe Dr. Epcon or Dr. Thien Prayun, you could give us some insight.
Sure, I can start with just a couple of thoughts. When Claudia, you were presenting your information and you showed the slide positioning in bed with the head in a certain position, it made me think about that sort of musculoskeletal pain that can manifest as a headache. And so, simple things like looking at the position in bed might be something to start with. I take headaches seriously. I think it was really important for that family to seek guidance from a pulmonologist or a sleep doctor, because morning headaches in the setting of Duchenne, in the setting of someone who has weak breathing muscles, can represent what we call sleep disordered breathing. In other words, you're getting enough oxygen, but frequently don't blow off your carbon dioxide, and it causes morning headaches. So that was the right thing to do, and always the first thing to do for morning headaches. assuming that that has been ruled out, I think thinking about either musculoskeletal causes or neurologic causes. So, really seeking help from a neurologist who's generally part of the neuromuscular team, but they might send you to a special headache doctor because there's different kinds of headaches. Migraines, for example, are going to be treated very differently than a tension headache or a headache related to musculoskeletal pain. And so I think having someone, when I hear about morning headaches, I think about having a neurologist help evaluate.
Great. Thank you, Dr. Epcon. Rachel, would you add anything to that?
I totally agree. It's the only thing I would add is if you can find a neurologist or a headache specialist who's at a center that has Duchenne specific teams or clinicians, that's likely to result in a plan that's more organized and comprehensive for you so that they can sort of run everything. They can see your records. They can run everything by the team that's normally taking care of you, just to make sure that everybody's on the same page with what's right for you.
Perfect. All right, with that, we'll go to our next question. I think this is probably a more straightforward answer, but a really good question to ask. And it comes from a woman who says, I'm a manifesting carrier with pain. I wanted to know if these concepts apply to me as a woman.
I would say absolutely, yes. So, I think, Rachel, you showed a wonderful slide that showed the progression of pain complaints, again, with the ages and stages of the Duchenne. While a woman might be fully ambulatory, she, like our ambulatory boys, may have pain complaints. And so I think that the things that we talked about are very relevant, very relevant.
I think all of the interventions that we talked about in terms of musculoskeletal interventions completely apply, to a woman that has pain.
Awesome. Thank you, Claudia. All right, let's shift gears a little bit and talk about steroids. So steroids are really commonplace in the treatment of Duchenne. A lot of guys are on either daily or weekend steroids, and we think about steroids both as treatment of Duchenne and then perhaps, steroid dose packs for other sort of acute needs. So maybe we could talk a little bit about how steroids can treat pain depending on the cause. I don't know, Dr. Epcon, if you want to start us off.
Yeah, I can start off, and then I'm going to hand the mic over. I think when I originally read the question, I could see it in the chat. I was thinking, I wonder if this person has had experience with getting a Medrol dose pack, and that's sort of the term that's used. It's a steroid pack, usually someone who has acute pain coming from a nerve root compression, so a radiculopathy. We oftentimes hear it's something that adults have. I've not really seen it in kids. I've not seen it in young men or men with Duchenne, but it certainly could happen. Those acute nerve compressions coming at the neck may respond beautifully to a steroid dose pack, but that's a very different use, a very specific use for that kind of pain. Typically in my practice, we aren't using steroids to treat the pain that we're talking about right now, certainly not the musculoskeletal pain or the fracture-related pain or even the visceral pain that we've described.
Dr. Thien Priyun, would you add anything to that?
Nope, I totally agree.
Perfect. All right, this next one, I think we'll start with Claudia. It's in regard to the TENS units. So some questions about the TENS units. Can a single unit be used on multiple different pain areas, perhaps one at a time? Could it be used on multiple different people? It seems like, she says, I ask because it always seems to be prescribed for a person's knee, for example. So could you perhaps repurpose that TENS unit? You're muted, Claudia.
Yes, absolutely. You buy the unit, you can get them online, and you buy electrodes, like a package of electrodes. They're just like flat and they're self-adhesive. So if you're using them on yourself, you can reuse those electrodes on yourself. If you're using, let's say the unit is shared by brothers, for instance, then you would want separate electrodes for those brothers. And they can be used on your back. They can be used around the knee, as she suggests. They can be used, say you have cramping in your calf muscle. They could be used for that. It would be good to consult a therapist for positioning of the electrodes. where do these electrodes get placed for the best results, and in terms of adjusting the intensity of the TENS unit. So a consultation with a physical therapist to actually get that first adjustment and to get some instruction on the use of the TENS unit, I think is probably the best thing to do, and actually which TENS unit to get online, because there are several of them and you want to get one that works well.
I think that's a great point, Claudia, that can be a really useful tool, but to use it in partnership with your medical team to make sure that you're using the appropriate tool in the appropriate way to be most effective and safe. Next up, I have a question about traction. Can we get a layperson's definition of traction and how it might be used in Duchenne?
So I was wondering if this question was going to come up and how I was going to demonstrate that for the hip. So traction is if I have two surfaces together and I gently pull them apart. So for instance, if I take my arm, we'll see how this works. So I take my arm and I gently pull on it. And I can feel it all the way up at my shoulder. And it's not a rough thing. It's not like I'm not going to pull that joint apart. I'm just trying to just gap it a little bit. On my finger, I would just gently pull, and it creates a space in the joint so that it just creates a little space in the joint so that you kind of decompress the joint a little bit. It's not something that a layperson would do without some training by a therapist.
Right, it looks like Claudia might have frozen for a moment, but I'm going to anticipate that she was saying this is something that you would really work with your medical team on if traction was a potential solution for yourself or for your child, and make sure that you're doing that in partnership with them. Sorry, Claudia, it looks like you're back.
That's exactly what I was going to say.
Perfect. I want to be mindful of time. I know that we're at the end of the hour. We've got a couple of really good questions that I want to toss to the group. And the next was one of my own questions, but I see somebody else submitted it as well. So for people who are nonverbal, pre-verbal, have difficulty with communication, what does assessing pain for those people look like?
I think parents know their kids best. And so we take a careful history. We try to understand the pattern that's happening, how the child's behaving, how their pain has manifested through behaviors in the past. If there are vital sign changes that can help us and give us clues to what's going on, sometimes that helps. We may need to do a thorough evaluation and get pictures and look for problems. We may need to do lab to look for problems to try to help us sort out what's going on. So I think it's being really thorough in our evaluation of taking the history. And then sometimes we try things to see if they help. So if the patient is acting like they're hurting and we try a little Tylenol and they get better, that's probably a sign that was pain. So it's sometimes a little bit of cause and effect, or try something and see if it works or not. But the main thing I think is that parents really know their children well. And so if a parent is worried that their kid is hurting, we take that very seriously.
Dr. Epcon, would you add to that at all?
No, I think that was a great response. I was distracted because it was a great question about a pain first aid kit. Do you mind if I take that one on, Rachel?
Please do.
I thought it was I like the way that was phrased. I think it's probably no different from a pain first aid kit you might take for your put together for your entire family if you were going to the cabin like you are at right now. Claudia, right? So having an ice pack, having some Tylenol or ibuprofen or the likes. There are some, none of us mentioned lidocaine patches can be very effective. Those are over the counter. There are some prescription grade, but they are over the counter patches that can be placed on an area that is painful. This person who wrote the question is very savvy and said that sometimes NSAIDs or anti-inflammatories like ibuprofen are out of the picture because of heart medications, and that's true. So I would recommend that you talk with your care providers, especially cardiologists. Some cardiologists who have kids on what are called ACE inhibitors, like lisinopril, they are filtered through the kidney and can affect the kidney. And if you add on another medication like ibuprofen, it could sort of have a little bit of a double whammy. And so they like to avoid anti-inflammatories. What I'll say is once in a while generally is typically okay, but it's the high dose scheduled frequently for multiple days that they try to stay away from.
Excellent. Thank you so much, Dr.
Things
Epcon.
I would add to the first aid kit: an ACE wrap, and you can get those ice packs that you break and then they activate.
Absolutely. Absolutely. Great tools to have on hand. This last question, I think it's intended for Dr. Thien Prayun, but I'm going to take it and then I'm going to toss the rest of the response to her. And the question is, how do you go about finding a palliative care team or even coordinated specialists when you don't live near a clinic and you can't travel to one? And I think that that's something that PPMD really tries hard to support families in. Please reach out to us. I am the director of our Certified Duchenne Care Center program, but as part of that, PPMD really tries to maintain relationships with healthcare providers all over the country. So if there's a way that we can be supportive of you with connecting with the team, please don't hesitate to do that. You can reach out to me or to anybody on the PPMD team. But Dr. Thien Prayun, how about finding palliative care when it's not necessarily accessible?
I'm dropping the website into the chat. Getpalliativecare.org has a provider directory for palliative care teams around the country. So you can drop in your zip code and see if you can find a team near you. If you're cared for at a CDCC Duchenne center, like people who come to us, I've had patients from Missouri, for example, who came having pain. I can't prescribe pain medications back in Missouri, but I did do research, find them a team and set them up with that team that cared for them when they got back home. So that's another way, sort of a hub and a spoke. When you come to your primary center, if it's not in your home state, you can ask to be connected with a team back home, and they should be able to help you do that. But if you want to look yourself, you can go to getpalliativecare.org and see what's available near you.
Wonderful. Thank you, Dr. Thien Prayun. I think being mindful of everyone's time, both our speakers and our guests, I see that we're a few minutes past the hour. I want to just express gratitude for Dr. Thien Prayun, Dr. Epcon, Claudia, for joining us today and sharing all of your wisdom and insight on pain management in Duchenne and Becker and carriers. We're really grateful for you taking time out of your busy schedules to answer our questions. So thank you for joining us. And thank you to all of our attendees for taking time out of your day to listen in and hopefully get some questions that you've had answered as well. This is recorded and will be available on our PPMD channels and YouTube. So feel free to go and check it out once we get it pushed out and available for playback. And please never hesitate to reach out to the PPMD team if there's anything that we can do to support you in your journey with Duchenne or Becker or being a carrier. So with that, I'm going to say one last thank you to my speakers and we will conclude today's recording. Thanks, everyone.